Hello and welcome to Chapter 22, Diabetic Emergencies and Altered Mental Status for the EMT. So let's go over some pathophysiology. So normal consciousness is regulated by this RAS, or reticular activating system. It is in the brain, and it does have basic requirements such as oxygen, glucose, and water. And it is responsible for staying awake, paying attention, and sleeping. So altered mental status is a symptom and not a problem. Um, so you have to kind of figure out why they're having that altered mental status and treat that, and hopefully it's correctable fairly easily. And we'll talk about those here in a minute. But altered mental status can be caused by deficiencies in the RAS requirements, so oxygen, glucose, water. If we can fix those three things, then we might fix their altered mental status. It can be caused by trauma, infection, chemical toxins, primary brain problems such as like schizophrenia or other mental illnesses. Narcolepsy is another one of those. And then problems within another body system. Okay, so the brain may be starved for oxygen because we're hypoxic. We have difficulty breathing. Okay, if we have difficulty breathing, then what can happen is you become hypoxic, and then your brain becomes hypoxic. So you got to correct the breathing problem in order to correct the hypoxia, and the hypoxia then should fix your altered mental status, or fixing that hypoxia should fix it. So just kind of an example, right? So how do we assess these patients? These patients can be dangerous to responders, so you want to make sure that you have your safety as number one, your partner's safety, and then everybody else. And then if you need law enforcement, you can call for law enforcement. Occasionally, I've had patients where we get called for diabetic emergency, and they are just they don't know what's going on. They don't have any idea of what they need to do to fix themselves, and so we may need law enforcement to help us. In our primary assessment, we're always going to consider the possibility of an airway or breathing problem, because that may be the cause of their altered mental status, or the airway problem may be because they have altered mental status, they don't have an open airway. So you've got to fix one or the other, okay? Be attentive during your primary assessment with a patient in altered mental status, and carefully watch for any kind of indications of inadequate breathing, okay? Be alert for the need for positioning your patient. Maybe they need to be placed on their left side in that recumbent or recovery position. Maybe they need to be placed supine. Maybe they need just a simple jaw thrust or head tilt chin maneuver to fix them. And also suctioning as well, because when you have altered mental status, everything kind of relaxes and your body goes into the parasympathetic state, and the sphincter that prevents backflow from the stomach up into the esophagus and out is relaxed, and so it can produce vomit from the stomach. They can aspirate, meaning that it'll get into their lungs, and yeah. So if you suspect any kind of hypoxia, then consider high flow O2. Be alert for indicators of hypoperfusion or shock. Determine baseline mental status for the patient. And this may be accomplished by greeting the patient and assessing their ability to respond. Okay, so AVPU. AVPU can help you categorize that patient's initial response. Are they alert, verbal, painful, or unresponsive? They can still be conscious and not be alert. Okay, so they can be conscious and have verbal stimuli. Need verbal stimuli. You just need to, poke them, pinch them, whatever. Mainly, maybe for painful. But the AVPU basically helps you to categorize what your patient is in. Okay. And baseline status can be difficult to determine in children because they answer questions differently than adults. Okay. Again, it's somewhat different, but also the same. Because if your child looks at you and does everything that you need them to do, they're alert. Okay. In kids, verbal stimuli would be that I talk to them and they cry. Okay. So that would be verbal. And then painful is obviously anything that elicits some type of verbal or painful response. So in our secondary assessment, altered mental status is that subtle sign that indicates some type of serious underlying issue. It could be caused by an issue, or it could cause other issues. Okay. So body system exam and complete history may reveal important information about the suspected cause. You want to interview family members and bystanders. You want to get the patient's baseline mental status before you ever get on, what it is normally before you arrived on scene. So like their normal day-to-day, what is their baseline? Can they tell me what day it is, what year it is, all those things. Sometimes those patients can't. You may have a dementia patient or a stroke patient. So you've got to figure out what their baseline is before you can move on and determine if this is an acute problem or a chronic problem. Review any kind of medications, medical alert bracelets, and any other health-related items for relevant clues. You'll also want to look at the scene and determine whether or not the scene can provide any clues as to why they may be altered. Be sure to document accurately the patient's level of consciousness over time. Does it get better? Does it get worse? Were they maybe alert but not talking to me when I first came in and now they're unconscious completely? Or were they unconscious when I first came in and now they're alert and talking to me and everything like that? Okay. The Glasgow Coma Scale is can be used to provide a measurement of the patient responses. It goes 4, 5, 6, and it has different categories for eye-opening, verbal response, and motor response. So the more you're alert and talking to me, you can move everything, and everything like that, you're 15. If you are dead, or unconscious and not able to talk to me, not able to do anything, not even moving from some type of painful response or stimuli, then that's a 3. So there is no 0. It's just a 3. All right, so let's talk about different problems that can cause altered mental status. So diabetes, glucose is a form of sugar, and it's the body's basic source of energy. The body cell requires the glucose to remain alive and create energy. After sugar and carbs are converted to glucose, glucose is then absorbed into the bloodstream. Okay, so glucose is this large molecule that cannot pass into the cell without insulin. Insulin is basically the key that says, hey, I'm going to take you along, and you're going to go with me, and we're going to go to the cell, and we're going to provide energy. And glucose is absolutely okay with that. Okay. Where do we get this insulin? It comes from the pancreas, and it typically happens when the blood glucose exceeds 90 milligrams. So when you drink a sugar, or drink a soda pop, or eat a candy bar, and your sugar goes above 90, the pancreas starts to produce insulin. And the insulin basically says, hey, we need to do something. And you're gonna go with me, okay? It binds to those receptor sites on the cells and allows the glucose molecules to pass. Normal glucose levels in the blood are essential to maintaining normal mental status, okay? Normal glucose is 60 to 100. And again, just because it's 58 doesn't mean I'm necessarily going to do anything. I'm going to look at my patient, figure out if my patient needs something, and then do something. So patients who are diabetic do not produce insulin. They may not produce enough insulin, or they have become resistant to the insulin that is produced. So insulin and the pancreas. So the pancreas has these islets of Langerhans, and those are what produce the insulin. Most of the cells outside of the brain use insulin to transfer large glucose molecules into the cell membrane. Insulin is that key that unlocks the cell and allows that glucose to enter. Again, it says, hey, come with me, we're going to go here, and you're going to provide energy to the cell. And then the cell basically says, okay, you got the right key, I'm going to let you in. When sugar intake and insulin production are balanced, the body effectively uses that glucose. Okay, so diabetes mellitus, this results from an overproduction of insulin or the inability of the cells to use that insulin properly. So you may not be able to produce the insulin, or your cells just say, I don't know what this insulin is doing, but I don't like it and I don't want it here. Okay, and insulin, that key, can't unlock the cell for the glucose. Type 1, this is when the pancreatic cells do not function properly. Insulin is not secreted normally. When there's too little insulin to transfer into circulating glucose into the cells, and synthetic insulin is typically prescribed to supplement inadequate natural insulin. Type 1 is typically diagnosed as a childhood disease, and these patients will probably get a pump, and they'll have a continuous insulin pump to be able to pump insulin in. They also adjust their insulin dose. There's a couple of theories, so you can adjust your dose based on just a normal dose. I take 20 units a day, or a sliding scale based on what they eat, what they're taking into their body, and what their glucose is. Type 2, this is a non-insulin dependent diabetes, and this is when the body's cells fail to utilize insulin properly. The pancreas is secreting enough insulin, but the body is unable to use it. That key isn't going into where it needs to go. Okay, it can be controlled through diet, oral anti-diabetic medications, and sometimes insulin. This is typically diagnosed in later adult years, and the patient can typically, because if you are going to the doctor regularly, it can be caught soon enough that you don't necessarily have to be on medication, and it can be controlled by diet and exercise. So when diabetes becomes a problem is a myriad of things. The patient can be sick, the patient can be non-compliant, meaning that they don't either take their insulin or medications, or and they don't track their sugars, um, uh, or it can be caused by something else. Seizures can cause hypoglycemia or hyperglycemia. They can cause um, various other things. Like I said, if the patient is sick, it can cause the sugar to drop because the cells need um, glucose to um, function, and it may take more glucose for the cells to function because they're being invaded by some foreign thing, and the cells need that extra glucose, so it takes it from the fat stores. If there's no fat stores, or the glucose is not, there's no glucose in the fat stores, then they can be hypoglycemic. Hypoglycemic is low blood sugar. It's caused by either too much insulin, too little sugar intake, over exercising or over exertion, vomiting, or an increased metabolic rate. And when that blood sugar is reduced, the brain and body cells starve. This can lead to altered mental status, unconsciousness, and even possible brain damage. Onset is rapid, and the signs include abnormal behavior, kind of mimicking a drunken stupor. That is why when cops pull over a drunk and they smell sometimes fruity, fruity something, they have to ask, any kind of medical problems or anything like that. Fruity is more on the hyperglycemic side, but anyway, they can act like they're in a drunken stupor. They may be pale, sweaty skin, tachycardic, rapid breathing. They may also have seizures that are caused by the low blood sugar, because if the brain doesn't get the blood sugar or the sugar that it needs to function, the glucose, then the brain says, hey, I'm not doing what I need to do, so I'm just going to kind of do what I want to do, and I'm going to seize because it kind of stops up. Okay. Quick replenishment of blood sugar is critical to the outcome for a patient with hypoglycemia. Oral glucose is often used. Patients have that know when their sugar gets low, or it happens quite often for these patients. They will have some type of either candy bar with them. They'll have some orange juice or peanut butter. Walmart sells the same tubes of glucose that we use on the trucks, and it's basically just like a sugar syrup that like a thick slurry sugar syrup that the patient takes. Or there's glucose tabs that are basically just sugar tabs. The cells of the RAS in particular need that glucose, which causes notable alterations in mental status. Hyperglycemia is high blood sugar, often caused by insulin deficiency. The body may be unable to produce insulin, and insulin injections may be forgotten or insufficient, or they may just not take it due to non-compliance. So yeah, infection, stress, and increased dietary intake are factors for these things. This develops over days or weeks. Signs include chronic thirst, hunger, increased urination, nausea, dehydration. The cells of the body slowly starve due to the fact that glucose can't enter the cells from the blood. Starving the cells begins to burn fats and proteins in a way that produces excessive wastes. This waste buildup and combines with dehydration to cause diabetic ketoacidosis. So we all know the diet, the keto diet. So it's not a bad thing as long as you are monitoring your ketones and your sugar. So you really have to pay specific attention to those things. You can't just go on a keto diet and not pay attention to those things, because you want you want your body in that state of ketosis, but you don't want it to go into DKA. So signs of DKA include profoundly altered mental status, shock caused by dehydration, rapid breathing, and an acetone or fruity odor on the breath. So when we assess these patients, the patient may be agitated or violent. We want to identify the altered mental status, and then gather a history from the patient or bystanders. And then we want to gather a history of the present episode. So we want to determine how the episode occurred, the time of the onset, and duration. We want to identify associated symptoms and any kind of mechanism of injury and any interruptions to the episode. Ask whether there have been seizures or a fever or the patient's been sick. I've had patients where they drink alcohol, and alcohol has carbs in it. And so their body produces all that insulin or doesn't produce the insulin, and they either get hyperglycemic or they get into hypoglycemic glycemia because the body overproduced that insulin. Okay. Determine if there's a history of diabetes. Look for a medical ID bracelet or wallet card. Note any kind of oral medications. Check for home glucose meters, and watch for this implanted insulin pump. So the one here shown is the typical traditional insulin pump. There are newer pumps out there, kind of like you've seen them, I'm sure, but they attach just like onto the skin. There's no pump to there's no like box pump to put on like a belt or pocket or whatever. It's just all in one type deal, and it's controlled by your phone. So there's those out there too. And then there's also the continuous glucose monitors that are basically the same thing. It's like a big patch type deal that goes on the back of your arm, the thigh, various other things. And you basically it circulates through the blood and gives you a continuous glucose reading at any point. So then we want to determine if the patient is alert enough to swallow without aspirating or anything like that. So if they have a severe altered mental status, if they are unconscious, obviously, or if they can't swallow, then we're not going to give them any kind of oral glucose. We're going to take some baseline vital signs. We're going to observe for signs and symptoms of a diabetic emergency. So rapid onset of altered mental status, they may be intoxicated or have that intoxicated appearance, cold clammy skin, elevated heart rate, and hunger. Observe for uncharacteristic behavior, anxiety, combativeness, and even seizures. So when a patient has a seizure, we have medicine that we can fix for the seizure, but we also have medicine that we can fix on the trucks fairly rapidly for diabetics. So you have to kind of figure out, does the patient have a history of seizures, and is this seizure related to the history of seizures, or is this a patient with a diabetic history and their seizure is caused by the sugar? So if it's caused by the seizure, they're not going to stop, or caused by a glucose problem, then they're not going to stop seizing until we fix their glucose problem. So we have to fix their glucose problem before we can fix their seizure problem. Not necessarily before, but to fix their seizure problem. Blood glucose meters. So these make it possible for patients to test blood glucose in their blood every day. Testing helps the patient know how much insulin to take, and when and how much to eat. Testing also helps reduce diabetic-related complications like hypoglycemia and hyperglycemia. The continuous glucose monitors can test as often as every 5 minutes via sensor under the skin. And we really shouldn't be using the patient's glucose monitor because those are calibrated once when they buy them, and then they're never calibrated again. They are pretty reliable, but we also want to just double check with our glucose meter, because I've had some patients, their glucose reads 41 and on ours it read 110 or whatever. So so less than 60 is symptomatic, and asymptomatic diabetic indicates hypoglycemia. Less than 50 causes significant alterations in mental status, including unconsciousness. And greater than 140 indicates hyperglycemia, and greater than 300 for a prolonged period leads to dehydration and more serious problems. So again, symptomatic, okay? They need to be symptomatic in order for me to start treating them. Now, the caveat to that is I've had one patient whose blood sugar was 14, and they were still alert and talking to me and actually making jokes and laughing and like cutting up. So did I give him sugar? Absolutely I did. I started an IV, I gave him some sugar, and he was even more happy-go-lucky after that. So just be aware that patients can present differently. Okay. Always question a reading that is inconsistent with the patient's symptoms. The test strip may have had too little blood, been expired, or been improperly stored. The meter may have been out of calibration, may not have been used properly or properly maintained. With this guy, I double checked his glucose with his and mine. I checked it like 2 or 3 times before I started giving him sugar, just because of the fact that it's one of those things that you're not like totally sure, because he's alert and oriented and talking to me and making jokes and all that stuff, but he was still sugar was still 14. And the other thing is that sometimes patients can live in a higher glucose range when they're a diabetic. So it's always important to know what their normal blood glucose is, because I had a patient the other day who her normal was about 260, and that's where she felt good. Now the doc didn't like it; they wanted her at like 140, but she felt the best at 260. So you just got to be aware that even though her sugar may be like at 60, that may be really low for her. So if she's at 60 and she's, complaining of altered mental status and not feeling good, you might want to give her some sugar, because her normal is at 260, and that's where she lives every day. So just be aware. Okay. So these meters do have a special display for very high or very low glucose rate values. A rating of high indicates an extremely high level in excess of 500, or I think our meters go up to 600, and then it reads high. And then anything low, I've seen a meter read about 8 before, but I've never seen it read low. So, occasionally mild hypoglycemia and minor altered mental status can be treated by eating or drinking. You want to determine if the criteria for administration of that glucose is present. So history of diabetes, altered mental status, and if they're awake enough to swallow. If they meet that criteria, then you're going to squeeze that tube of glucose directly into the mouth. Reassess your patient after administration. If there is no improvement, you're going to consult medical direction. If the patient is unable to swallow, you're going to treat as you would with any other mental status, secure an airway, provide artificial ventilations, and be prepared to perform CPR. If you don't need to do ventilations, just place them in a recovery position so that way that keeps their airway open, and request ALS. The most important decision point in choosing to give oral glucose is the patient's ability to swallow. Hypoglycemic patient may need the sugar, but if the airway cannot be protected, oral gel is not appropriate. Only administer that oral glucose that the patient is able to swallow and can protect their own airway from aspiration. So hypo versus hyper. So onset with hypo is usually slow. Hypo, it comes on all of a sudden. Skin is warm, red, dry in hyper. In hypo, it's cold, clammy. Their breathing, so their breath, they typically have an acetone breath with hyperglycemia, and in hypo, they won't have necessarily a specific smell. Patients with hyper may also breathe deeply, be intensely thirsty, and have abdominal pain or vomiting. It's not necessarily necessary to distinguish between the two conditions to give proper treatment in the field. Oral glucose is recommended for anyone with a diabetic emergency. It does help the hypoglycemic patient, and it's not necessarily going to harm the hyperglycemic patient, but we also don't want to give them that sugar if they don't need it. So other causes of altered mental status, so seizure disorders, if the brain function is upset by some type of injury, infection, or disease, the brain's electrical activity can become irregular. This irregularity can bring about a sudden change in sensation, behavior, or movement called a seizure. There are several different types of seizures. A partial seizure, though, only affects one part of the brain. It can involve just like an arm seizing or the face seizing, or one hemisphere is seizing, so one side of the body, so like if it's the left side of the brain, the right side of the body is going to be seizing, and vice versa, and they may still be alert and oriented. Generalized seizures affect the entire brain and affect the consciousness of the patient. We're typically called for the type of generalized seizure called a tonic-clonic seizure, which is characterized by unconsciousness and major motor activity. It has a tonic phase and a clonic phase, where the patient, the tonic phase is, they're basically relaxed, kind of not doing anything, and then a clonic phase, which is where they tense up. So the tonic-clonic, it happens rapidly in succession to each other. There's often no warning, and patients will thrash wildly, and the entire body is involved. Sometimes there is a warning, and they can have an aura, they can have unusual smell, unusual taste, or anything like that before the seizure happens. And then the body, when the body gets ready to have a seizure, it actually puts off a distinct odor, and that is why service dogs can warn people that they're getting ready to have a seizure. So the tonic-clonic seizure has three phases. There's the tonic, where the body is rigid for up to 30 seconds. The breathing may stop. The bowel and bladder control may be lost. and then a clonic phase where the body jerks violently for 1 to 2 minutes. The patient may foam at the mouth. The face and lips may also become cyanotic. And then we have a postictal phase where the convulsions stop, consciousness is regained, and the patient may be drowsy or may be violent. Sometimes, though, if the patient does go into like a status seizure, there is no postictal phase, and the patient stops, or they don't regain consciousness, and then they go right back into a seizure. So the most common causes of seizures in adults is failure to take their prescribed anti-seizure medication. They're non-compliant. In infants, it's usually a high fever, so we call that a febrile seizure. And other causes include hypoxia, stroke, and a traumatic brain injury. It can be from toxins, hypoglycemia, brain tumors, congenital birth defects, infection. Could be a metabolic problem or an idiopathic problem, meaning that there's really no rhyme or reason why they had the seizure. It just can happen. Stress can also cause seizures as well in a epileptic patient. Epilepsy, measles, mumps, and other childhood diseases, eclampsia, heat stroke, and onset of syncope can also cause seizures. So epilepsy is an umbrella term used to describe multiple seizures of an unknown cause. It may be present from birth or may develop later due to injury or surgery. And most people take medication that allows their epilepsy to kind of stay at bay, and they typically live a normal life without having any seizures if they take their medicine. Occasionally, the medication will have to be adjusted. They'll either have to use more medication or they'll have to go to a different medication. And that's typically when you get called for these patients because they're switching medications. So the medication that they were on has now suddenly stopped and they have to build up enough of the medication that they're currently on, or that they switch to prevent the seizures. You want to get an accurate description of the seizure, so that way you can let the ER know, because typically we don't see the seizure. Occasionally you will, but most of the time you don't. You want to gather any kind of information from bystanders. What was the patient doing before the seizure started? Was there any kind of aura? Exactly what did the person do during the seizure? Was there a loss of bowel or bladder control? How long did the seizure last? And what did the person do after the seizure? So patient care. A patient seizing on arrival is a priority transport. If you are present when a convulsive seizure occurs, we're going to lay the patient on the floor or ground, loosen any kind of restrictive clothing, remove objects that may harm the patient, protect the patient from any kind of injury. Do not hold the patient still during the seizure, and if there is a vagus nerve stimulator, allow the family members to apply the magnet. A vagus nerve stimulator is basically this thing that stimulates the vagus nerve to kind of slow the body down and slow the brain down. And what it does is there's a magnet that they place over a certain area, typically like the chest or the back of the head, and it will basically just slow everything down. After the seizure has stopped, we want to protect the airway. If they're cyanotic, we may need to provide O2 or artificial ventilations, and then treat any kind of injuries that the patient may have sustained during the seizure. So if they fell, we want to protect C-spine and anything like that. And if they want to be transported, then we're going to transport them to a facility. It used to be common practice to put a bite stick into the mouth for a seizure not too long ago, because it was kind of going out of style when I was getting into EMS 16 years ago, 17 years ago. So it's just one of those things, we don't do it anymore. Okay. 2 or more convulsive seizures in a row or a single seizure of more than 10 minutes is status epilepticus or status seizure. It's a high priority patient. It requires immediate transport and ALS. Because if we don't stop that seizure, the brain could have lasting detrimental effects from that seizure. Simple partial seizures involve tingling, stiffening, or jerking of one part of the body. Aura may occur. There is no loss of consciousness, and in some cases, the jerking may spread and develop into a tonic-clonic seizure. Complex partial seizures is characterized by abnormal behavior that varies widely. It can involve confusion, a glassy stare, aimless motion, lip smacking, or fidgeting. This is typically diagnosed as kids with a complex partial seizure, and the people who recognize it the most are the teachers in school. So teachers pay attention to their kids, and they know when little Johnny is having some type of issue, because it either happens every day, it happens multiple times a day, where they just kind of stare off into space, and then nothing really brings them back. But then the teacher may recognize it and say, hey, there's something going on. They may appear to be drunk or on drugs. They may not be violent, but may struggle if restrained, and the seizure is often preceded by an aura. There's no loss of consciousness, but there is no memory of the episode either. Generalized seizures include 2 types. There's the absence or the Petit-Mal seizure. This is a brief 10-second temporary loss of concentration or awareness. It may occur hundreds of times per day, but it does not involve any kind of motor activity. And then that tonic-clonic seizure involves the entire body. So here is a seizure.
Babe, I need you on the floor. You know, it's okay. There you go. There you go. Get to the floor. There you go.
And this would be a full tonic-clonic seizure.
You're okay. You're okay. Babe, can you hear me? Can you hear me? Can you hear me?
And here we are in a postictal phase.
It's okay. It's okay. Can you hear me? Babe.
You can see he bit his lip or tongue, and there's a little bit of blood.
Can you hear me? Maybe. Babe, can you hear me? Babe.
All right. So patients with epilepsy tend to be knowledgeable about their condition, and seizures may be common. They may also refuse transport after the seizure has happened, and then just ensure that the patients who refuse transport are not left alone, and do not drive. Um, yeah, it happens occasionally where you get called for a seizure and the patient doesn't want to go. Um, but there's a reason that they had the seizure. They may be sick with some type of infection. They may not be compliant with their medications, or they may need to readjust their medications. And so it's important to know that. Okay, strokes. This refers to death or injury of brain tissue from oxygen deprivation. We can have an ischemic stroke, which is caused by some kind of blockage, the thrombus or embolism obstructing an artery, and then a hemorrhagic stroke, which is caused by bleeding from a ruptured blood vessel in the brain. This is often the result of long-standing high blood pressure, and it can also occur when a weak area of an artery bulges and eventually ruptures. This can also occur from falls or something like that. When you have a patient, so ischemic strokes are more likely than hemorrhagic strokes. I think there's like an 80% chance more hemorrhagic or ischemic stroke than there is hemorrhagic strokes. Different patients exhibit different signs, and depending on the size and location of the arteries involved. They may have one-sided weakness or hemiphoresis. They may have difficulty speaking or the complete inability to speak. Headache caused by bleeding from a ruptured vessel. They may have some type of deviation of the eyes, and they may not be able to recognize parts of their own body. Communicating with a stroke patient may be difficult because it can because damage to the brain affects the word use. So aphasia is a general term for difficulty communicating. In expressive aphasia, the patient knows what they want to say, but uses the wrong words. My grandmother had this when she had her stroke. She could use words and know what she wanted, but she couldn't say it very well, or she'd say the wrong word altogether. So like she wanted a cucumber, she'd say watermelon, and various things like that. So receptive aphasia is when the patient cannot understand you, so they respond in ways that don't make sense. Okay, so the portion of the brain that controls speech and connection is messed up. TIAs, this is when a patient exhibits some type of stroke symptoms, but they do not last any more than 24 hours. I've seen strokes last 30 minutes. I've seen strokes last up to 2 hours after that. So TIAs typically resolve within 24 hours. These are small clots that temporarily block circulation to part of the brain, and it causes those stroke-like symptoms. And then when that clot breaks up, the symptoms resolve, and a period of hypoxia is short, and there's no permanent damage. This patient is at risk for a full-blown stroke and should be evaluated as soon as possible. Stroke scales. So these, you can ignore the names, the red, but stroke scales. So there are several different types of stroke scales out there. There's the RACE scale, which is what we currently use at Mercy, and it's a rapid arterial occlusion evaluation. The NIH, or the National Institute of Health, has a stroke scale. There's the LA pre-hospital stroke scale. There's the Cincinnati pre-hospital stroke scale. And then there's the FAST for face, arm drift, speech, and time. The FAST stroke scale is typically what we think of when we think of a stroke scale. But RACE is what we typically use. Excuse me. So the Cincinnati pre-hospital stroke scale is based on the FAST. So we're going to ask the patient to grimace or smile. If there's an abnormal response, or if it's unequal or there's no movement, we're going to ask the patient to close their eyes, extend their arms straight forward for 10 seconds. If it's abnormal, then one arm may drift or not move, or for the arms to turn. Ask the patient to say you can't teach an old dog new tricks. They may have some slurred speech, wrong words, or no speech at all. My phrase that I use is "the sky is blue in Missouri," again, just look for any kind of slurred speech. All right, so this video.
It was a real-life scare for Wendy Williams on Halloween morning.
We've got a lot to talk about.
Because the talk show host passed out live on air.
It's time for our How You Doing Halloween costume contest. We do it every year. It's always a lot of fun. Let's get started. Our first caress.
The show cut to black and went to an extra long commercial break, nearly 6 minutes long. But when it did come back on, Wendy was back up.
That was not a stunt. I'm overheated in my costume and I did pass out. But you know what? I'm a champ and I'm back. I want to thank Jerry O'Connell and Dave Messages. Is that the end of the show? Was I passed out that long? No. Well, thank you, Jerry. Thank you, Dave. I love you for watching today.
A rep for the 53-year-old tells ET Wendy is feeling much better. She overheated because of her heavy costume, makeup, and lights. Wendy's rep adds that the host will address the incident more on her next show.
So, at the very beginning when she started having symptoms, she looked like she was having a stroke, okay? If I had just seen that portion, they said she was overheated. I believe she went to the hospital after the show just to get checked out. But if I had seen it and saw her symptoms, I would have said she was having a stroke. So, alright, I believe we have another video. Not that one, but this one. This one is of a news reporter who does have a stroke on air.
Lady Antebellum was the big winner tonight with 5 Grammy Awards. Rapper Eminem, the big shocker, winning only 2 despite 10 nominations. CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go to Terrace Chasing those for the bit. They had the pit. We had a very Darrison, but let's go ahead Terror chases the vet that had the pet.
So she was having a stroke. I think it was actually a TIA. And but she, got better. So.
Lady Antebellum.
So other signs and symptoms that can fluctuate in severity: confusion, dizziness, numbness, weakness, or paralysis, often one-sided; loss of bowel or bladder control; impaired vision; high blood pressure; and difficult snoring or respirations. They can have nausea, vomiting, seizures, unequal pupils, headache, loss of vision in one eye, and unconsciousness, although it is uncommon for that. Recognition is the most important step in a stroke. Many conditions mimic a stroke, but it's always better to over-treat suspected stroke. Stroke is time sensitive, and the longer the vessel is blocked, the more damage will occur. And the most important treatment is often rapid transport to an appropriate destination. So for conscious patients who can maintain their own airway, calm and reassure them, monitor them, high flow O2 if they need it, and transport. For unconscious patients, you're going to maintain an open airway, administer O2, and transport. So use of some treatments is time sensitive. The patient must meet specific criteria for clot busting drugs. We call this like TPA. There's thrombin, plasminogen, activator. But basically what it does is it's a medicine given to break up a clot. So it can be given. Typically, the treatment is about 6 hours or less to give the medicine. Some docs may give it up to 12 hours after the onset of symptoms, and it's been given up to 24 hours with the onset of symptoms. So you have to know when those symptoms started, okay? So if you have a patient who went to bed at 10 o'clock, got up in the morning, and they woke up with symptoms, then their last known well time was 10 o'clock, because we don't know exactly when that stroke occurred. If they went to bed at 10 o'clock, they woke up at 8 o'clock, but they were fine, and then at 9 o'clock their symptoms started at 8 o'clock or sometime in there. So you want to know when symptoms started and when last known well time was. So you may have somebody who says, well, I was on the phone with them like 2 hours ago and they were fine. So that is typically our last known well time, and that's the time that we go with symptoms starting. Dizziness and syncope. These can indicate serious or life-threatening problems sometimes. You may be unable to diagnose the cause of syncope and other causes of altered mental status, but you can treat life threats and gather information. So you're going to determine what the patient means by dizziness, because it can mean a myriad of things. So you want to ask them if they have any weakness. Is the room spinning, or are you spinning? Is there any kind of lightheadedness as well? Syncope is a brief loss of consciousness with a spontaneous recovery. They can have some type of warning that it's going to occur. They may experience lightheadedness, dizziness, vision changes, or sweating. And sometimes they can lose bowel or bladder control. Cardiovascular causes for dizziness and syncope would be bradycardia, tachycardia. They may be having a heart attack. They may have some type of abnormal heart anatomy. They may have a sensitive carotid sinus, and then stimulation of the vagus nerve as well. That's why when you go to the bathroom, you don't bear down too long or too hard, because it will stimulate that vagus nerve and cause a vasovagal syncope. Hypovolemic causes would be dehydration, internal bleeding, trauma. Metabolic and structural causes would be an inner ear problem, hypoglycemia, strokes or seizures. Patient can have environmental and toxicological causes such as alcohol use, drug use, carbon monoxide poisoning, panic and anxiety attacks, and any kind of other causes as well. You're going to rapidly identify and treat any kind of life threats. You're going to ask the questions to gather important information during the secondary assessment. You're going to describe what they mean by dizziness. Did you have any warning? What was it? When did it start? How long did it last? What position were you in? And have they had any kind of similar episodes in the past? Are you on any kind of medications for this problem? Do you have any other signs and symptoms? Did you witness any unpleasant sight or experience any kind of strong emotion? Did you hurt yourself when you had the episode? And did anyone witness any kind of involuntary movements, like seizures? So patient care, the greatest danger for a patient with a syncopal episode is falling. So we're just going to ensure that the patient is in a safe environment, help the patient into a safe position at the floor, and provide aftercare. So if the patient, lay the patient flat, loosen their clothing around the neck, administer oxygen based on need, and then call for ALS and treat any kind of injuries that may have occurred. The patient may need a C-collar, depending on if they fell, hurt their head, neck, something like that. Okay. All right, so any questions, let me know, and I will answer those to the best of my ability.